Good evening, everyone, and my name is DEBRAJ SHOME, and thank you for having me here. Certain financial disclosures are in order. I've been a faculty with Allergan Medical Institute and MERS, the companies which make the botulinum toxin and the fillers for the past 15 years. And I'm also a faculty with the company which makes the largest number of threads. The eyes say it all. That's the reason we are all here. And the reason we are all here is because when people look at each other and look at each other's eyes, that is what makes all the difference, especially in a world where the rest of the face is covered by the mask. You can have the entire face looking pristine and young, but if the under eye area does not look young, there's no way to hide age. So from that perspective, the eyes say it all. In all of us, and also in some aging Bollywood superstars. So you can see a difference in the last 5 years that this superstar's face has undergone. And while the rest of the face looks okay, it's really the under eye areas which have borne the brunt of age. We all understand this. And why am I showing this slide which everyone knows about, the OG curve? The OG curve is best seen on a young female's face, usually at 45 degrees. It comes as a concavity below the eyes, followed by the convexity of the malar area, followed by the concavity and then the convexity of the maxillary area as well. Why is this important? This is important because the symmetry of the eyes actually demonstrates symmetry of the face. And when you look at people very closely, socially we've been programmed to look into each other's eyes. And that's the reason you've been paying very careful attention to this model, but you've not picked up that there is an asymmetry in her lips. It's really a very badly done filler job. She's one of the best known models, but you've not seen it because you were paying attention to the eyes, to the corneal reflex, and to the brow area. And that's the impact, mesmerizing as it may be, that the eyes have on people. Now, this slide is actually the most important slide of the presentation. And why is that? Because you have to understand aging in order to create anti-aging. And what is aging? Aging is mother gravity being ever so kind, pulling everything downwards and medially. So if all the facial tissues are moving downwards and medially, essentially what is happening is as we age, the fat pads which were below the eye are sliding downwards, giving rise to the tear troughs. And then you have the folds which are appearing in the nasolabial area. So from that perspective, this slide becomes extremely important. We conducted India's first aging paper, which has now been published in Plastic and Reconstructive Surgery, which is the highest impact factor journal in plastic and reconstructive surgery. And that showed that in Indians, the tear trough increases disproportionately as we age. Also, this is related to the melanin content in our skin because we are mostly Fitzpatrick 4 to 6 skin. And that's what gives rise to the aging as we know it. So therefore, if aging is downwards and medial movement of tissue, anti-aging would be upwards and lateral movement of tissue. And that's going to be very important in the slides forwards. So all in all, we understand this. The thinnest skin of the human body is the under eye skin. And then this thin skin is also being made to move continually 7 to 10 times, 15 times a minute because you're blinking all the time. And so this under eye skin, which is very thin, shows the earliest signs of ill health, stress, and aging, depending on whom you ask. If you ask a dermatologist, they would say fillers will solve all. If you look at an oculoplastic surgeon, they'll probably say blepharoplasty is that sort of a panacea. But the fact of the matter is diagnosis and treatment of under eye problems requires a systematic diagnostic approach and individualized treatment for all our patients. Let's talk this through. So if in a patient like this, I asked you, would you look at medical management or surgical management or both? Given the fact that this room is made up of ophthalmologists and oculofacial plastic surgeons, you'd probably say, I would like to do a lower eyelid blepharoplasty, and you're not wrong. But the fact of the matter is, even if you did a blepharoplasty, you will create a sign of cachexia underneath the eye. And the textures, the tones, the blemishes, and the quality of the skin can never be treated with surgery alone. And that's the gap that we need to address. So all in all, looking at it morphologically, and this is a paper that we are now writing up, we like to think in terms of topography. It becomes easy to teach. If you think in terms of mountains and valleys, it becomes easy to teach everyone. And so we talk in terms of under-eye problems being divided into 4 major topographical, if you look at it like a landmass, the troughs, the tunnels, the valleys, and the mountains. And let's look at each one of them individually. So what are troughs? That's the tear trough deformity, right? Formed by the ligament, we all know about it. What are tunnels? The problems caused by the hypertrophic orbicularis oculi muscle. What are valleys? The problems created by the displaced suborbicularis oculi fat pad, or the SOOF as we know it, and the displaced under-eye bags, which are called the mountains as well. Now, this is a paper which we just published, and this is something that we'll be speaking about as we move forwards. If you are thinking about the under-eye area, there is no good way to treat the under-eye tear trough without first raising the cheek. If you can take this as your take-home message going home from here, I will have accomplished what I wanted to do in this presentation. Because the cheek is coming down and the descent of the midface is responsible for the development of the tear trough, please do not just go and stick a needle in the under-eye area and try and fill it up. That's what leads to people looking artificial or looking as they didn't look in their youth. What we first need to do is pull the cheek up. And do it for yourself. The moment you pull your cheeks up in this manner, you see your under-eye looking better already. And that's a paper that we published using a high G' filler. Because usually when you're looking at under-eye fillers, you're looking at low G' fillers. But what is the low G' filler? A low G' filler is a filler which is like water. But when you put in water in the under-eye area, it lasts less. 6 to 9 months is what you get. And it looks artificial as well. So using a high G' filler would paradoxically cause the filler to last much longer. You'd have less bruising because you're not going into the medial part, and therefore this works better. This is something that we call the G-point lift. So this is this paper which talks about the types of tear troughs that we have, but especially if you look at grade 2 and grade 3, you can see that the hollowness is all over. It's periocular and it's all over, and therefore you need to address the hollowness all over as well. And again, if you're using a low G' filler like a Juvederm Volbella, you'd need 2 syringes per under-eye area. Tell me which patient can afford that. So as a result of which, using the high G' filler becomes important. And how do we use the high G' filler? As in here, which is use the zygomatic injections, use the lateral maxillary injections, use the injections on the periocular rim laterally and inferiorly in order to raise the eye and raise the canthus as well. This is a technique called myomodulation. And what myomodulation means is that when you get the filler in underneath the orbicularis oculi, the orbicularis oculi actually tightens up like a hammock, leading to the medial side looking far better. So paradoxically, while you're injecting the fillers laterally, because it's a high G' filler and is raising the orbicularis oculi, you're actually ending up making the medial part look better. Therefore, the bruising, etc. is much lesser, the filler lasts longer, people look much more natural and look like they haven't aged at all, as opposed to looking like caricatures of themselves. Now let's look at a few patients. Now that's a really young patient, 28-year-old, model director. She wants to look young. Now this is like a grade 1, right? In this particular patient, you'd be well served in just going ahead and putting the fillers in. It's a low G' filler. It's a simple in, simple out, half a syringe of a lower G' filler on either side. 15 minutes, patient looks like this. This photograph is not taken 15 minutes after. Photograph is taken next week. But you can see how the lid cheek junction has narrowed, how the eyes look much more natural, and you can see clearly how she looks much more happier, if you will, and rejuvenated if you must. Then there will be patients who will come in with eyes like this, but here you can see the periocular hollowness is beginning to set in. And in patients like this, we would actually use a high, please, I would request photographs not to be taken. We would like these patients to be treated with a high G' filler, as I demonstrated in the paper, because what that does is that causes the cheek to go up, and by causing the cheek to go up makes the lower eyelid look much more relaxed and rested. Now this is a patient that I borrowed from my friend Dr. Milind Naik. Not every patient will have hypertrophic orbicularis oculi which are this marked, but then there will be patients who when they smile their eyes can't be seen at all. And especially when you consider that as we are aging, the brow fat is descending continuously and all the time, and most people look better with slightly larger eyes. Therefore, using the botulinum toxin which is injected in this manner in the hypertrophic orbicularis oculi. And we don't necessarily do it like this. We do 2 points, which are below the medial and the lateral limbus, and causing the eyes to open up when the patient smiles makes them look much better. Now let's look at this particular patient. This particular patient came in and wanted to know if they need ptosis surgery. This patient had been diagnosed by various surgeons that they had seen all across the country, and they wanted to have a ptosis surgery in order to make both palpebrae look similar, palpebral apertures look similar. But if you look carefully, the problem is not in the upper eyelid. MRD1 is the same in both eyes. It's actually the lower eyelid, and the lower eyelid has an inferior scleral show. And that inferior scleral show, when she smiles, makes her left eye look much smaller than the right eye. Now you start to understand why this is a problem for her. Because when she's smiling under a high definition camera, as she usually does, this makes her left eye look almost 20 to 30% smaller. But should we do ptosis surgery in this? Of course not, because the upper eyelid is where it should be. So therefore, what did we do? We went ahead and actually put in a little bit of Botox. So the hypertrophic orbicularis oculi is treated in the manner we discussed earlier. Put in a little bit of a lower G' filler in the tear trough. And once you've done that, that's what the patient becomes. And after they smile, now they look much more symmetrical. So essentially, the patient does not have the eyes becoming smaller when they are smiling. Now, some patients will come in. This is a 32-year-old lady. She comes in with an eyelid bag. But the eyelid bag is very asymmetrical. It's more on one side than on the other side. Can you do a blepharoplasty? Oh, sure, you could do a blepharoplasty at age 18. But the question is, do you want to do a blepharoplasty? Is she ready for the risks, the downtime of a blepharoplasty? And so if the answer is no, then just putting in a high G' filler in the manner that I showed earlier would cause her to have these sort of results. And this is immediately post the injection. You can actually see the injection marks at this moment in time, which could actually camouflage the mountain. So your question to your patient should always be, should I remove the mountain via surgery, or should I camouflage the mountain by putting filler beneath so that the mountain cannot be seen? And both are acceptable alternatives depending on what the patient wants. That's the patient 7 days later. Now, obviously, if G-point lift is what is required, there's a way of lifting the cheek which doesn't necessarily have to rely on fillers. For people who are in their 60s or 50s, just using filler takes a lot of filler in order to raise the cheeks. So using the thread lift becomes an important way to do this. Now, let me demonstrate what a thread lift looks like. But in essence, a thread lift is a non-surgical procedure which is done under prilocaine and under lignocaine. This is a cork thread which is being done. It's like the stem of a rose, which has thorns all the way around. And these are being put in under local anesthesia and then being cropped close to the skin. They will engage the fat pads and cause the cheek to go up. Similar sort of process for the G lifting, which in turn makes the under eye look far better. Now, if you're doing periocular rejuvenation, lasers are critically important. So as an oculofacial plastic surgeon, either you need to have a dermatology in your practice or you need to collaborate with a dermatologist. Because trust me, if you're not dealing with lasers, you're never going to be able to treat the tear troughs as well as combined treatment will. And the two workhorse lasers that we use are the fractional CO2 laser and the Q-switched Nd:YAG laser. The fractional CO2 being for the fine lines and wrinkles and rejuvenation and collagen production, and the Q-switched Nd:YAG laser being the pigment laser for the dark pigmentation of the Indian skin, which we see typically in Fitzpatrick 4 to 6 skins. Now, these are some of the patients with combined therapy, and you can see how the under eye looks far better after combined treatment. And you can also see in cases which have small eyelid fat bags, you can actually tighten the skin just by doing carbon dioxide laser. So if you did carbon dioxide laser, you can actually tighten the skin, making the entire periocular eye area look far more rejuvenated. And this can be then addressed without surgery as well. These are some other patients. And in the photograph on your bottom left, you see that it's post the CO2 laser. You can see the grid of the CO2 laser and the combination of the toxin, fillers, and laser resurfacing and the changes that this can cause, especially for the crepey skin, which otherwise becomes very difficult to treat. Also, surgical results can look far better with the laser. So for instance, in a patient like this in whom we performed a mid-face lift, we performed a blepharoplasty, we performed a brow pexy, you can actually give a couple of sessions of laser, even one, and then the scars look much better, they merge better into the surrounding skin, and therefore give far better results. That's another patient of the same. That's again a patient post-blepharoplasty, but sometimes these crepey skins and especially the malar mounds or the festoons do not disappear just like that. So using the laser becomes an important tool in order to increase the collagen production in that area and therefore make the periocular skin look far better. Scars is something that we deal with regularly in the periocular area. And this is an algorithm which we published using botulinum toxin, carbon dioxide laser, and certain creams which can make the scars look far better. And you can take the patients from there to there to there, where the scar almost becomes imperceptible over a period of time, but after multiple types of treatments, obviously. Sometimes people post-ptosis surgery will develop some sort of pigmentation. And going ahead and using the laser can remove that pigmentation as well. So even more reasons why the laser should be available. So carbon dioxide laser is something that we do very regularly, and carbon dioxide laser can actually make your skin results look far better. So all in all, beautiful eyes is equal to a beautiful face, and the under eye area can show the first signs of aging. And obviously, because people in this room came from an ophthalmology background and moved into oculofacial plastic surgery, it gives you a disproportionate advantage to treat this particular area, especially in a world where the mask covers the rest of the face. But most importantly, having a wide armamentarium of synergistic procedures is very important. If the hammer is the only tool you have in your kit, everyone will look like a nail. I thank you for your kind attention and a very patient hearing.
Thank you, Dr. DEBRAJ. Excellent presentation. Just have one question for you. For the patient with that tunnels under the eyes, where you'd given Botox, I noted that you'd given Botox on the brow also, suprabrow region also.
No, that's Milind's way of doing it. I don't do it in that manner.
I saw it on the...
Yeah, so that was a slide from Milind. Okay. It shared acknowledgement Milind Naik. So we do it only in this area, and we do it in two places, which is just below the medial limbus and just below the lateral limbus. If the hypertrophic orbicularis oculi is a lot, 2 units either ways, or just a single unit in the midpupillary line.
What is the logic behind injecting suprabrow? Why did he do it? Any idea?
No idea.
For a brow lift.
Yeah,
could be. Usually
simultaneous brow lift to open up the eyes a little more.
We inject it in the orbicularis so that the frontalis works well and lifts the brow. But this was above the eyebrow. That's why I asked.
So if we have to use botulinum toxin to lift the brow, the most important thing is to paralyze or to lessen the action of the depressors.
Exactly.
So the corrugator supercilii in the central here would play an important role. The procerus in the midline would play an important role. Only if those two are not working as well would the only elevator of the forehead, which is the frontalis, be able to raise the brow. So that might have been the reason why he used it.
Because usually if women want a temporal brow lift, we give injection just below the brow temporally so that the frontalis lifts it up temporarily, but medially what you say is...
Senthil, what I would suggest
the corrugator is there, so if you inject on the corrugator, the frontalis will work.
So what I would suggest is, if we are going to do a chemical brow lift using the Botox, we should go and do the procerus and the corrugators as well. That'll, just doing that without even this particular point causes the medial brow to go up and causes the brow to look much more relaxed because the depressors are now not acting. And then using a little bit of Botox below the orbital part of the orbicularis oculi, which is below the tail of the brow, is something which would cause the lateral part to go up as well. The central brow is injections are also very important for men, because in men you don't want to inject this point because you'll get a flare which will look very artificial in men.
Thank you, DEBRAJ. Excellent presentation.
Thanks, Santu. Thanks so much.
DEBRAJ, excellent. Once just for use, as per your one pre-op photograph use, there is a blepharoptosis kind of thing. With laser, are you prefer only carbon dioxide laser or with surgery or some multiple therapy?
No, sir. No, Dada. I didn't say that we were treating the ptosis with the carbon dioxide laser.
No, there is a use just brow ptosis like a...
Yeah, so that was a surgery. That was a surgery in which we did an internal brow pexy, we did a ptosis surgery, we did a blepharoplasty. All that I was showing via that slide was that the scar was looking far more amalgamated because post the procedure, we used the laser couple of passes in order to make the scar post the surgery merge well into the surrounding skin.